I would like to cite two papers that, in my opinion, have suggested important ideas. The first one was by Susan Mansi almost 15 years ago, saying that people with lupus have a high risk of myocardial infarction. And in particular, she noticed that people with the age of 35 to 45 have almost 52 times an increased risk when compared with the Framingham Offspring study or sample. The next one is one that my mentor did with the cohort of a clinical cohort in Montreal. He suggested with his student that patients with lupus have two different mechanisms of developing ischemic heart disease or coronary artery disease. They were able to tease out that both the disease activity modulates factors that influence the risk of cardiovascular disease, but also the glucocorticoids. And this is important for what I'm going to present today. We also know that people with lupus have not only coronary artery disease, but other forms of ischemic heart disease, including venous thrombosis and stroke. Traditional risk factors do not explain the increased risk, similar to what has been seen in other inflammatory diseases, including rheumatoid arthritis and non-arthritic diseases, but within chronic inflammation. So the studying outcomes that are rare in rare diseases with lupus make these hard to study, and that's probably one of the reasons why we don't see big studies on cardiovascular risk in lupus at the population level. Most of the samples usually come from clinical cohorts usually seen at tertiary care units. So with this in mind, we use this study, and I will explain the sample and from where it comes from later, to see if people with lupus at the population level had an increased risk of myocardial infarction compared with the general population. We also wanted to see if the risk remains constant once a patient has developed the disease, and compare those with the observed ones in the general population. So for those who do not know, the Canadian system is, in Canada, is a universal healthcare coverage. And in BC, the province where I live, that includes almost 5 million people, everybody gets coverage. And our data sets include all the medical visits, all hospitalizations, and all medications dispensed to the population with different time periods. For the purpose of this study, we include people who were seen between 1996 and 2010. And the drug data include those years. We use an algorithm to define the disease or cases. All were adults, and we use a definition previously used by another colleague in Quebec, Dr. Bernatsky. We define a case with two ICD-9 codes or ICD-10 codes seen as an outpatient by a non-physician, non-rheumatologist within 2 months and within a 2-year period. Or a case could be also selected or defined if it has an ICD-9 code or ICD-10 code from hospital or a code made by a rheumatologist. In order to increase the specificity for this case definition, we also exclude cases once they made the definition if they were seen, initially not seen by a rheumatologist, but subsequently were seen by a rheumatologist, and the rheumatologist did not confirm the diagnosis, then cases were excluded. Furthermore, for this study, we use sensitivity analysis. In addition to those case definitions, we add the use of drugs commonly used for the management in lupus. Glucocorticoids, antimalarials, immunosuppressive drugs, methotrexate, between 1 month before the index date or within 6 months after the case definition met criteria. This is just to make the cases more stringent. So we develop a case control cohort matched by year, sex, and calendar year. We define the outcome. We use incident cohort. This is new cases of lupus, and also the outcome was incident cases. We excluded cases who had an MI prior to the index date. We calculated incident rates, And we also adjust for several confounders associated with cardiovascular disease, including COPD, cardiovascular disease, including hypertension, obesity, cardiovascular drugs, diabetes, contraceptives, hormone replacement therapy, etc. So this is the characteristics of the group with the wider definition, with just ICD-9 codes. We identify almost 5,000 people. The mean age was 48, and 90% of the cases, or close to 90% as you will expect, were female. And there was significant difference in the baseline characteristics. In particular, cardiovascular risk was increased, number of hospitalizations, and the Charlson Comorbidity Index. And those were adjusted in all adjusted models. Just to, we select 10 cases for each case, and these cases were selected from a random sample selection from the underlying population of BC. And as you expect, it was easy to match by age and gender. So the truly random sample. So on the upper one, I'm presenting now, from now on, both cohorts, the ones with the case definition using only ICD-9 codes, plus, and at the bottom, the ICD-9 codes plus drugs. We lose 20% of the sample when you use drug definition. So in total, we identify 196 cases in the lupus patients, and in the non-lupus patients, we identify 640, giving us an incidence rate per 1,000 patient years of 9.5 versus 3.3. Very similar results on the case definition using drug. So when we're trying to identify there was a difference in the risk between genders, and overall, the sex and the adjusted model show that in the case definition only using ICD-9 codes, the risk was close to 3 times, 2.6 for females, and slightly elevated for men, but there was not statistically significant difference because the confidence intervals actually overlap between the two. Very similar results for the case definition, including medication. Then we decided to see if there was a significant difference between different age groups, as Dr. Manzi had suggested very early, 15 years ago. And we observed that, again, the higher risk is in the younger population, but it was not as high as in their study. This was almost 6 times, or 5.6, and comes down. And probably this is related because we don't see in the general population MIs at each age group, and the comparator groups makes a big difference here then. So, but as the population ages, we start seeing probably more events in the reference population. But overall, the highest group was around 6 times more. This is a survival curve just to show you the probability of remain event-free, in other words, not having MI over time. The blue line represents the general population, and the red line represents lupus. It's constant, and they don't overlap. So we also wanted to see if the risk remains constant over time, and we observed that the highest risk actually happens within the first year of the disease duration. The risk was 5 times more during this time compared to the risk, which is closer to half after 5 years of disease duration. And similar results were seen when we use the case definition using drugs as part of the algorithm. So as any study has limitations and strengths, I will start saying the limitations in ours. Of course, when you use administrative health data, you are uncertain about the reliability of the diagnosis. We try to do the most specific case definition ever used to define lupus. And when we use that definition with the generic one, the results were very similar. So it's probably that we'll have not true cases, but that's a conservative bias, because then our risk will be even higher. We actually include those who truly have lupus. However, we feel confident that we can live with that. Also, we don't have clinical of laboratory data yet. We're working on it. And there are some important factors that are increased risk for MI, and this is smoking. And you know smoking increases the risk of lupus, and this could be an important factor that needs to be adjusted for. However, we think we have some strengths. This is a population-based study, including all lupus patients. We have a strict definition. We use a longitudinal follow-up for all. We have drugs for all, and we use a standardized control for all. And I would like to finish saying that to my team and the funding agencies and GSK Canada, who partially support an investigator-initiated research project with this specific outcome. Thank you, and I'm open for questions.